Hello, I'm speaking with Professor Jim Rourke from Memorial University in Newfoundland. How are you, Jim?
Just fine, and great to connect all the way across the world, or maybe this communication goes right through the center of the earth to get to where you are, because we're almost that way connected.
Absolutely. So we're going to talk about your paper today. It's one of a pair that were published together. The first one is, Does Rural Generalist Focused Medical School and Family Medicine Training Make a Difference? And it's the experience of Memorial University of Newfoundland outcomes. And the paper we're going to talk about now is From Pipelines to Pathways, the Memorial Experience in Educating Doctors for Rural Generalist Practice. Maybe we could first go through the research team, Jim.
Well, this was a great collaborative effort, and the research team included the doctors who were heavily involved in all aspects of the training. So I'd start with Mohammed Ravalia, who is a rural doctor, and he's the doctor in charge of the Rural Medical Education Network. Dr. Michael Jong is also a rural doctor practicing in Labrador, a remote part of the province, doing remote extreme medicine, and again, one of the leaders in rural medical education in Canada. Dr. Wendy Graham is in the other corner of Newfoundland, Labrador, again a rural doctor, heavily involved with Memorial and training rural doctors. And then we get to the team at Memorial itself, people like Dr. Wanda Parson, who's the Assistant Dean for Admissions, and we know how important admissions is in terms of this. We'll talk more about that in the paper. Mm-hmm. Then we've got Dr. Nora Duggan, who is the coordinator for the family medicine training component at the undergraduate or the MD program level. And then we've got Danielle O'Keefe, who is the postgraduate program director for family medicine training. And it's important to note that in Canada, all postgraduate training, vocational training, is done by the medical schools. So that's a very position that she has. Dr. Scott Moffat, who's the Assistant Dean for Student Affairs, and we know especially with distributed programs how important it is to provide support for students who have challenges because they're far away. And then we have Dr. Catherine Stringer, who's the chair of family medicine. Of course, that's sort of the team leader for family medicine. And then we have Carolyn Sturd-Sparks, who is the head of our Aboriginal Health Initiative, which, because in Canada a lot of Aboriginal people or Indigenous people are rural, and we want to make sure we're including them in our programs. Then the research team included Janelle Hippie, the original research assistant who developed the database we used, followed by Dr. Kristen Harris-Walsh, and then Oliver Hurley, who are the research assistants, using GIS, Geographic Information Systems Analysis, that tell us where did they come from, where did we train them, where did they end up. That's sort of, it's not just Google uses GIS people or municipalities, but we use them in medical education now. And then Dr. Shabnam Asghari, who's the research director for the Center for Rural Health, an academic researcher who, again, we find in rural health research it's so important, someone like that who really knows the science of research more than perhaps these rural doctors do. And so that was a team. It was just a great team that we had while working together on this project. And it was interesting to do. The project was set to do 50 years after the founding of Memorial Medical School as a rural-focused medical school in a very rural and remote province. Our capital city, St. John's, is officially just over 100,000 people. In the region around it is only 200. Yet we've got 500,000 people spread over 400,000 square kilometers, like northern Queensland.
Wow.
It's that kind of remote area, except you get the 40-degree temperature heat there. We get minus 40 up in Labrador in the wintertime. And many of the places reachable by plane or by skidoo in the wintertime, it's very remote or extreme medicine. And yet we've got some of the near rural things that are closer to St. John's as well. So the whole bit is really pretty exciting.
For sure. So in the previous paper, you talked about the outcomes of this research. What difference does having a rural medical school make in terms of the coverage of the people living in Newfoundland? So this particular paper, From Pipelines to Pathways, is a more general look, or?
Yeah, well, exactly. So the first paper was a look at, so what have we done? Like the so what of it? You know, we've had this folks medical school. what are the outcomes? And it turns out the outcomes are really good for the people in Newfoundland and Labrador and for rural people in general across Canada. So we're pretty excited about the outcomes when we analyze the outcomes. This paper is, so how did you do this?
Yes.
That answers the question, what did you do to get these outcomes? And what we found at our medical school was, it was called pipeline to practice. So the original concept of a rural medical education pipeline was coined by in the United States, and it seems to make sense in a way, but it sort of thinks that people are confined to a pipeline. Once you're in it, you're sort of forced along the way. And we found that it's more a pathway to rural practice, that people come in at different times, and some people think they want to be a rural doctor from before they're even in medical school. Other people might have experienced medical school that gets them turned on to rural medicine. Other people might come to it later in their vocational training, and that we need pathways that are flexible enough to allow people to come in and also go out if it's not for them. So our pathways start all the way back in high school.
In high school?
And we found it very important. Yes, indeed. And so in high school, we have an outreach program that encourages bright students to come into Memorial for the summertime, for part of the summer, and find out about health professions. Not just medicine, but nursing and all the related health, pharmacy, all the related health professions, to try to encourage them to see this as a career.
Yes.
And we've extended that to Aboriginal or Indigenous communities as part of our Aboriginal health pathway, because we really want to make sure we get those people into medical school as well, because we're short of Aboriginal or Indigenous doctors in Canada. The official term in Canada is Aboriginal by the legislation, but we tend to call them Indigenous people. And so we've worked very hard all the time to get them in, but we've got this great pathway going now that's very successful at preparing for medical school, getting me into medical school, and then supporting Indigenous students in medical school and developing cultural safety and sensitivity and understanding in all medical students. So it starts in high school, and then in Canada, the medical schools are graduate entry. So people have to have a degree first before they start medical school.
Right.
So again, much of this stuff we reach out to people when they're in university, especially those with no background, try to help them along the way, and especially our Indigenous students, we try to help them with all the steps towards admission. And then the key is admission. And, in Canada, there's half as many people from rural background in medical school as there should be. In our medical school, it's about 50% of our students have a rural background, so it's way different than Canada. But we strive to make sure that our admission process is very open and inclusive and doesn't have the barriers that most other people have. So we've got a admission process that looks at what have they done, demonstrated altruism in their life portfolio. What have they done to help others out long before they're applying to medical school? We look at their marks, but it's not that big a thing. We don't have science prerequisites. People don't have to do a science degree at university. They can come in from anything. University level musicians or athletes, turns out, make great doctors, but they can't get into most medical schools. We focus on a very broad admissions process that allows people from a whole variety of backgrounds to come in. And we are also really looking at the experiences of rural people. So if somebody's been working the summer helping out the farm or helping out their father in the fishing boat, or their mother with her rural community-based work, those things count for good things. It's not just the rich urban experience that gets people the ticket to medical school.
Right.
And then we found that once you get into medical school, it's important to get them out really early on. So in every year of medical school, students have a rural experience as a compulsory part of our training. At every year, the 4-year medical school training, starting right from the first days of medical school. And that's important that they see what rural is, because the rural students, they need to be reinforced and connect back to the rural areas to keep that spark going. But rural people, it may not be on their agenda at all. It may not be in the radar screen at all. So unless we get them out, it's there. And we've got our clerkship now, although it's not an official longitudinal integrated clerkship, they can spend their entire clerkship outside of St. John's, and St. John's is only like just over 100,000, between 100 and 200,000 people. So that's pretty small by most big medical schools would consider that a rural center. Well, that's our and so we can get them out to the rural areas for almost their entire clerkship training time, which is the clinical focus years in medical school. And so we found that's been very effective. But the pathway has to continue beyond medical school. Mm-hmm. And in Canada, we're really fortunate that it's all organized through the medical schools for admissions, the medical school program, the postgraduate vocational training, and continuing education by and large. So we've got responsibility for the whole thing. And so our postgraduate training focuses training generalists of all types, and particularly rural generalists. Mm-hmm. So we have what you could call a rural training stream. Mm-hmm. Our family medicine program is a rural training stream that aims at giving all of them the competencies that they need to train for rural. Mm-hmm. And it used to provide a variety of rural experiences. They get to sample all different parts of Newfoundland, Labrador. But it became known as a bit of a bounce around residency and not as popular for that reason, even though the outcomes are good. So we've changed now to having the residency. Family medicine training is only 2 years in Canada, mm-hmm. so it's a very compact time, but to spend most of the 2 years in one rural region. And we're finding out now that that is a super way to learn. It's like a longitudinal residency, but it's also a super way to recruit and retain, because if they spend most of the 2 years in one community.
Right. So you think it's the community connections, or?
Build the community connections with not just the colleagues in the hospital, but with the community.
Right.
And recreation and living there. And guess what? That's where they want to practice.
Right.
So the side effect of having a longitudinal residency training program is that in the communities is the recruitment just naturally flows. This study would suggest that the residency training, vocational training, is at least as important where you do that as where you do medical school.
Wow.
And we're doing research now to try to look at the differences between where you do, is it medical school, is it residency, or both, but the residency program is at least as important as where you do medical school. So that's a snapshot of our program, and then we follow that along with doctors in practice. So we provide continuing medical education for them. We provide faculty development for them. We try to bring that out to the community so they don't all have to come in with regional programs to develop them as teachers. Because again, we find that the rural doctors in rural practice, once they start teaching, it invigorates them. They want to stay in rural practice. And it's really good things. We found that as well. And now we're training to become researchers, because we think, again, if we can support rural doctors who are full of ideas, do rural health, rural community-based research, then again, communities will be better. But the side effect is they're enthused and they want to stay in the community longer. So it's this whole pathways that starts before medical school. And actually, we look at it going all the way until the doctor's retired. And even after retired, we try to get to do locums to fill in the places that are short. So it's a lifelong approach. I think that we found it contributes to our success. It's not one button to press. It's you got to press all the buttons all the time. And partner with the government and communities. Like that's the other part about it. Our government has been very supportive of this program because they have the need. So we're working with them to answer their need, but in return, they're funding us to do that because we're part of the solution. We're not the problem. Again, the partnering with the communities is so important to have that community buy-in to physicians and trainees, the students. And so it's all the partnership stuff that makes it work. That's the magic. That's the magic glue in the pudding. I guess that's maybe the wrong metaphor, but whatever. But as you can see, we're pretty excited about our outcomes, and we thought, well, the outcomes of this could we really better describe what the heck it is we're doing, because that's what are you doing to do this, right? So, we're delighted to have Rural and Remote Health provide us feedback and help us get these papers to the good point they are now, because I can't say enough good about Rural and Remote Health and the editorial process and the back and forth on that that really helped us narrow down and get the papers refined.
Oh, thank you, Jim. We're delighted to publish your paper, and any quality papers, we're really welcome. Yeah. So thank you very much for talking about your paper. Hopefully talk again soon.
Great. Thank you. Great to talk with you. Keep up your good work at Rural Remote Health. We want that journal to keep on giving rural doctors around the world the information they need to know to keep on improving the rural health of people everywhere.
Thanks, Jim.